Great. So, good morning, everyone. This is Dr. Munjal. Let's start with the main things. Today, I compiled various questions of different subjects. So, you just check your things. I want everyone to be a more sincere. What I'm talking to many doctors every day in Dubai, out of Dubai, India, and other parts of the world. I think you need to increase your commitment level. This is little out of the our MCQ, but this is what I felt in last few months. Few tips today I'll give you. If you follow it 100%, I can record my things. You will 100% pass the exam. First thing is like you need to download the mobile application. Right, excellent MCQs are on fingertips. We recently updated on Android and iPhone as well to avoid the speed problem. So we recently updated all codes officially, right, with the Apple and this. So now much faster. Second thing is the mock test what I'm conducting every Sunday without failure. You must attend live class. You lucky in that sense that you are getting good knowledge at no cost. So you just need to just sit in front of computer and keep your mind and eyes open. What I'm talking about, that makes your lots of clarity in your mind how to prepare and what to prepare. Third thing is we have excellent channel MCQ for all where hundreds of videos are at your just fingertips, right? You just need to see one video a day. Believe me, if you see one video a day, almost your major course is covered in just one video a day, believe me, right? So I have uploaded on our YouTube channel. The today's video is also uploaded by afternoon, evening. So try to make a habit of doing one video, saying before you go to bed, you just see one video a day. That brings lots of clarity to your mind. And another thing is, last but not the least, try to do a mock test. At least those who are full timer in this, at least do minimum two mock tests per week. Minimum. If you do alternate, I would be glad and happy. And try to assess yourself. Where are you standing? What's the score? Why it's not improving? Right? What's the problem? If you have problem, contact me directly. My team, any coach you contact. Right, sir? I'm not getting the desired score. What to do? Right. So if you are in touch with the expert, there is no way to fail. Believe me. If you wish, you cannot, because your preparation is so well organized. They will not ask you out of the way. They'll ask you the basic question. They ask you the something common one. 80% of your paper is common, believe me. Right? Lots of people are asking, sir, what they ask, which book to read. Right? Honestly speaking, if you do two things, our website, our videos on YouTube, and master the board, there is no way you can fail. Believe me, there is no way. Right? For you, just this is a small lecture or the small website, medical MCQ for all. But I spent my 15 years and almost I'm practicing for more than 20 years. So, and still I'm working very hard, right? Going every 3, 4 months to Dubai meeting, trying to understand the problem. So I think you need to increase your commitment level. That is little lacking. So try to be more sincere. This lecture is not for me. This lecture for you. I'm not going to appear for DHA, hard MOH, right? You guys are appearing. So try to sometime make timetable. Try to give more commitment to your work. Do sincere hard work for at least 2 months. Believe me, this exam, anybody even can start from zero from today. 1 month he gets the excellent idea. 2 months he will be expert, and beyond 2 months he is ready to go for any exam. Believe me, right? And last but not the least, people think hard is extremely hard exam. Absolutely not. It's myth. The fact is hard is not hard exam. Our preparation is not up to the mark, right? So I have many students who crack the hard in first attempt. So if someone has the phobia, someone has a, the bumps in the mind that, oh, it's difficult to crack, you cannot crack it. Absolutely wrong thing. So try to increase your commitment level, your vision, your goal, your passion about the quality preparation. 110% you will crack the exam. So let's start. I observe this for many visits in Dubai in last year. 4 or 5 times I visited. I noticed this. We have student who crack the just exam in 10 days, 15 days. If you wish, I can give the number. Don't believe me, you directly talk to them. So it's not like that it is undoable, but we need to increase our commitment. That's it. That is the bottom line. So let's start with the things and check your score. Today you check your score. Out of the few questions, how much you did right, how much it's wrong, where are you standing? right? And if you have any problem, you are in a good and safe hand. So feel free to call me, contact me, my team anytime. So I would be more than happy to guide you. So let's start with the first questions. This is can anyone confirm my screen is visible well? Yes or no?
Yes,
Yes,
sir.
sir.
Wonderful.
Yes, sir.
So for those new, quickly we provide all Prometric 1000 book ebook online subscription, Oman Viva coaching, data flow, short package, mobile application, and mock test. Right, it's all on the website. I'm practicing hemato-oncologist for more than 20 years now, and I'm a member of many American Society, Indian Medical Association, blah blah. And Dr. Arti is a consultant pediatrician delivering excellent lectures in our coaching. Dr. Maddie is internal medicine. You must see the ECG videos of Dr. Maddie. Amazing. So those who are weak in ECG, go to the channel and see the video of ECG, how to interpret and various complex ECG is what they routinely asked in exam. She explained very well. Dr. Ankit is gastroenterologist. Dr. Shikha is now based at Dubai with Esther. She is in our team as a consultant gynecologist. Dr. Deepali is in Mumbai. Dr. Mariam Hillard recently joined. She is from US neurologist and a lot more things. Couple of more doctors. Dr. Sonal Shah is from Mumbai. She will joining soon for emergency medicine. And this is our contact detail. Those who are fond of getting the books, this is hard copy book and there are lots of various offers from 50 to 70% discounted. You can inquire later on. And data flow services is also by Dr. Anjali based at Dubai permanently. So you can contact her or me or anyone in our team. And this is various packages. So I don't want to go much in detail. You can inquire later on. This is absolutely mandatory things for you guys. YouTube channel. This is the name and picture and photos of the YouTube channel. So you must subscribe it and see one video a day, as I told you, right? So you get better with this. So let's start with the first questions today. Check your score. You check your score. You don't need to show me. 70-year-old woman present to her emergency department complaining of dizziness. She is disoriented to the date and her location, and it is difficult to gather an acute information or history. Her pulse is 48, blood pressure is 84/60, respiratory rate is 12. On examination, her extremities are cool and calm. Her capillary refilling test time is 5 seconds. What is the most appropriate therapy? You think over it. I am not in hurry. Post your answer in the chat box, right? Those who are new joining first time, I'm giving this try to everyone, right? Any MCQ, this is MCQ, this is called as MCQ, this is MCQ, this is question. MC means multiple choice and Q means question. So compiling this multiple choice question, so this is a question and this is a multiple choice, right? So you need to select from the multiple choice. So every MCQ you need to ask yourself from today onward, what's the diagnosis, what's the investigation, and what's the treatment of this patient. If you do this practice 110%, right, you feel that, oh, DHA is so easy exam, unnecessary I was worried about, but we are not doing the practice, right? Genuinely. So I need a three answer in one question. So if you are solving today 10 question, at least 40-50 MCQ will solve in next 1.5 hour. Post your answer in the chat box so we can discuss. This is absolutely interactive session. Don't worry about posting the answer right, wrong, what someone says. Post your answer. Think if this questions comes in your exam, what you gonna post? That's it. You don't need to shy. Post your answer in the chat box. Yes, Dr. Anupama Dubey, your answer is a B. So can we little discuss about this question so we get a clarity more on this? Yes, Dr. Anupama, if you can able to speak up now, you can unmute your mic. This is absolutely interactive session. Learning.
Hello,
Yes,
sir. Am I audible to
yes,
you?
yes. I'm absolutely. You are absolutely audible. Go ahead.
Okay. Sir,
So
the
what's the
age of
diagnosis in
patient,
this patient? First of all,
sir,
we'll go step by step, doctor. What's the
sir,
diagnosis in this patient? What do you
maybe
think?
she is
What could
in
be?
shock,
Okay, which kind of shock do you think that this patient, or
septic, sir,
types of shock? Sorry.
septic.
Whatever you are telling me, I'll write down just for learning. So lots of learning in today's lecture. Every time we have learning, but septic shock. You think this is septic shock? Now
Sir,
tell me
because
the
BP
point.
is low,
Okay, so tell me the point which favors the septic shock. How you
there's
define
pulse.
differentiate septic shock, hypovolumic shock, neurogenic shock, right? Anaphylactic shock and cardiogenic shock. This is what I remember. If anybody has more shock classification, they can add six name. This is what I remember very quickly. So everybody, so now tell me, Doctor Anupama, how you gonna differentiate? What points favor that this is a septic shock, this is not a hypovolumic shock? How you differentiate?
Mm.
Is
Sir,
there any
pulse
thought
is,
in your mind?
sir, it's a little
So
confused.
let me ask you. No problem. This is learning. I'm happy at least you are interacting. When there is a
Mm.
septic shock, the name itself suggests there should be some kind of sepsis in the body.
Right. Yes, yes, sir.
There should be some kind of fever in the body.
Fever.
There
Yes,
must
sir.
be some leukocytosis or increased neutrophil count or some history of infection of foci infection either in a GI tract, either in the lung or pneumonia, right? Or blood
Yes,
culture
sir.
positive, right? If anybody wants to have any comment, interrupt me. Don't worry. It's absolutely learning platform, right? So this is so. Do you think something is given in this history like
No,
this?
no, sir. No,
Fever,
sir.
eye
No
count,
fever.
foci, lung. So how did you get the idea of septic shock then?
No, sir. No, there is no fever.
Fine, fair enough. Leave it now. Leave it
Yes,
now.
sir.
Right?
Mm.
So what is the definition of shock then? Now you tell me what is the definition of simple definition of shock? If I tell you define the shock, how you define the shock? Tell me. There must be some definition. 101 degree fever is shock.
No, sir.
45 pulse rate is shock.
No, no,
What is
sir.
the right? 15 or
Sir,
12
it's a
respiratory.
cardiovascular collapse
Right. But how you
with
define? I mean,
hypoperfusion.
how you define shock? I mean, if I want to define in a one line, how you define? I mean, I want to understand your concept. We knows everything, but we need to know the basic things as well.
So
If I
multiple
tell you
organs going into
some
failure.
patient in shock, right? There are five shock, no septic, hypovolemic, neurogenic, anaphylactic, cardiac. But one thing is very common in shock. What is that? Irrespective of any shock that is there. Anyone
BP
can
will
open.
be
This is
reduced. So
sorry.
decrease organ perfusion.
Okay, so one thing is reduce organ perfusion, right? Organ perfusion. Is there any cutoff line for blood pressure? Below this much, you can say shock.
Less than
Below
90.
that, above that, you cannot say this is
Below
not a shock.
90.
90 over 60, less than 90 over 60.
Okay, so that's fine. I mean, we'll keep it systolic. Anything less than 90 is
Less than
considered as
90.
a shock until proved otherwise. Until proved otherwise. So basically, this is a life-threatening condition,
But
shock, right? Where you can say it's a circulatory failure, right? Or reduced circulatory failure, eventually reduced organ perfusion, then organ failure, and eventually death, right? So there are various kinds of shock. So those who do not know what is the difference between septic shock and all, right? You must go and read it. You must go and read it, right? Let me tell you very quickly in a one liner, very quickly in a one liner. If you want to remember all shock in one line, remember this the common thing in shock. What is a common? Low blood pressure.
Mm.
Anybody with the normal or high blood pressure is not considered as a shock, right? Right. So this is the absolutely one parameter should be there. And low blood pressure means at least less than 90 systolic. 120 over 80, you cannot tell the shock. Septic shock, the striking feature, fever. Look for the history, look for the MCQ fever, increased count, total count, urinary tract infection, pneumonia, GI infections, profuse diarrhea, anything which suggests the infections, considered it is a septic shock. So in history, there must be something, right? That okay, patient presented with fever, cough, pneumonia, blood pressure 90, probably septic shock, right? Hypovolumic shock. Hypovolemia means volume is reduced. The name itself suggests no need to mug up, just apply your brain. Reduce hypovolemia, volume reduce. So in volume, there are two things in blood, either fluid or plasma, and another is a blood. Right? These are the two things. So if it is a blood, it's blood loss shock and fluid when acute gastroenteritis, 30 times diarrhea, right? Dehydration, severe patient present with the 80 systolic. Here, major road traffic accident, 2 liters of blood went out because of fracture femur, 80 systolic. Both are the shock. This is hypovolemia. Volume is reduced from the circulation, either fluid or blood. Second, simple. Here, there must be blood loss, there must be history of major road traffic accident, history of hematemesis, history of melena, history of GI bleed, history of internal bleed, rupture, triple aortic aneurysm, blah, blah, long list. Anyway, blood is lost and here the fluid is lost, right? So this is what the common thing. Absolutely it will be given in the scenario, there is no doubt that they will not give you, but we are not I mean patience enough to read the history properly. Neurogenic shock, the beauty of this shock is like neurogenic. What do you mean by neurogenic? So something wrong in the neurological system, so either CNS, brain or spinal cord. If there is an injury, that cause neurogenic shock. Only striking features, most of the all shocks has two features. One is low blood pressure and another is a high pulse rate is high. Neurogenic shock is something in which blood pressure is low, also heart rate is low. This is differentiating point from all the shock with blood pressure and heart rate. Dr. Guru, you can add it. Dr. Sonal, if you're there, both are emergency guys and ICU guys in meeting, right? So if something is additive, you can add. I would be glad, right? So CNS, right, and neurological injury. This is third shock, fourth shock, right? Anaphylactic shock, anaphylactic shock. So anaphylactic shock is one of the most easiest shock. Either you must have history of peanut, either you must have history of egg, either history of some food, or sulfur drug, or chemotherapy the drug, right? Or penicillin containing drug. So any kind of exposure followed by shock, it's absolutely a classical for anaphylactic shock. No need to mug up. No need to mug up, right? So if you have seen 10 years of boy eating peanuts suddenly develop with a skin rash, hypotension, bronchospasm, tachypnea, hypoxia, blah blah. It's anaphylactic shock. You don't need to mug up, right? Treatment of choice is anaphylactic shock, epinephrine. We'll see sometime in emergency class, dedicatedly, just for your knowledge. And cardiogenic shock. So cardiogenic shock is something wrong with the heart, right? Something wrong with the heart, especially the most common across globe is a acute coronary syndrome or ischemic heart disease. That's it. Right, that's it. So only history, if you read the history properly, 110% I can guarantee you, you can easily identify what the kind of shock it is. Right. So this is what the basic, it's little out of the questions, but you must know this. This is absolutely important, and I don't think so. Nobody has seen the shock emergency in their medical practice. If you are in ER, you get hypotension, you get a shock, right? So just back to the business. What is the amiodarone? Why, Dr. Anupama, it's amiodarone? What is amiodarone? Let's discuss to the point. What's the amiodarone? If you don't know, you just tell don't know, just to save the time. Fair enough. Yes. Anyone wants to try on this? Anyone wants to try? There are a lot of answers here, right? Yes. Yes, Dr. Nasrin, any comment here?
So amiodarone is an anti-arrhythmic drug. So I don't think so amiodarone will be the
So what do you
answer.
think? What's the answer?
So for me, sir, here extremities are cool and clammy, sir. We can see cool and clammy in sir, cardiogenic shock and hypovolemic shock. Neurogenic shock, we see warm
Fair
extremities, sir.
enough. Fair enough.
So,
Septic
sir,
shock, usually you have a warm. Septicemia, septic
yeah,
shock, you
yeah,
have
septic
warm.
shock also warm
Anyway,
extremities.
fair enough, fair enough. So now how you answer this patient? What is the most appropriate therapy? So there are three things now, as I told you: diagnosis,
Hmm.
investigation, and treatment. So in MCQ in exam, either they ask you diagnosis, how you, what's the diagnosis? Sometimes they ask you what, how you investigate, and sometimes how you treat or therapy. So they are asking for the therapy or treatment. So how you treat this patient? Somebody is presented with these symptoms and vitals.
So I will say cardiogenic shock, sir, I guess.
Fair enough. What's the answer then? What do you want to give in this patient? Tell me.
Actually, patient is Brady, 48, and I will go with atropine option C.
Fair enough. Fair enough. Yes, Dr. Javeria, your comment, Dr. Javeria. What do you think? What's your comment?
The patient is in a Brady, so and the
Yes.
second is the neurogenic shock. So option C, atropine.
Excellent. So atropine is the most appropriate answer here, right? So write down in your notes symptomatic bradycardia. Two things: symptomatic bradycardia. Definition of bradycardia you must be knowing, but just clarify you: 60 to 90 is a normal heart rate. Anything less than 60 is a bradycardia. Anything more than 90 is a tachycardia. So anything less than 60 is a bradycardia, and when there is a patient has a symptoms, dizziness, right, disoriented, right, symptomatic bradycardia, only one answer is atropine. Let me twist the questions. If some patient comes to your OPD with 48 pulse, same patient, but absolutely asymptomatic, what's the treatment?
Nothing, sir.
Dr. Sonika, how
So
you
wait
treat
and
this
watch.
patient? Any idea? If you have some patients in your OPD, right, for just routine checkup, and you got 48 to 50 pulse, right, and now he is asking, sir, it's so low. He's an intelligent guy, right? He is
So
a
first
quite
of all,
well
I'll do an
educated.
ECG.
You do an
I will
ECG.
do an
Excellent. Why?
ECG.
Okay, so uh, ECG you will do,
Yes,
right?
sir.
So another questions, Dr. Sonika, learning purpose. Why you want to do a ECG in asymptomatic patients?
So because there could be a cardiac block, so as
Okay, there
to,
could be a cardiac block.
yes,
Okay,
or it could be sinus bradycardia.
or it could be
So I,
sinus bradycardia. Okay,
yes, sir. So as to differentiate whether it is pathological or it is just physiological bradycardia.
okay, fine. So which block? I mean, how many types of block?
So there are different blocks. One could be a complete heart block. Then,
Fine. So let me
so,
interrupt you here. Sorry, complete heart block is never asymptomatic, just for your knowledge, right?
okay.
So it could be either first degree or second degree at most, especially first degree, where
Yes,
just there
sir.
is an increased PR interval. That's it. Otherwise, nothing wrong, right? First degree,
Mm-hmm.
second degree. There are two type: Mobitz one, Mobitz two, and third
Mm-hmm.
degree means complete heart block. So complete heart block is never ever asymptomatic. For your knowledge, just I mean understanding. Fine. Sinus bradycardia. What other any other differential diagnosis of bradycardia? So if you have bradycardia, 48 pulse in your clinic, in your OPD, what are the differential diagnosis? One doctor told excellently, Dr. Sonika, block. It could be for second degree. Sinus bradycardia. What could other things possibility? Dr. Guru in your ICU.
There's sick sinus syndrome.
Excellent. Six sinus syndrome. Six sinus syndrome. What else? What else? Commonly, what else?
So,
Sorry, yeah, go ahead. Whatever the things in your mind, speak up only. That's it.
Athletes are usually
Sorry,
athletes. They'll be having sinus
athletes, excellent.
bradycardia
Athletes.
without
That is
symptoms.
physiological, basically physiological.
So
So
maybe drug
athletes are,
induced.
yeah. So
Drug
drug is
induced.
also, yeah, beta blocker is the commonest drug people
Yeah.
knows, right? It reduces the heart rate. So that could be this. So these are the things. So as Doctor rightly said, Dr. Sonika, whenever any ECG comes, right? Oh, sorry, whenever any bradycardia comes, low bradycardia, low heart rate, you need to ask the patient whether it is asymptomatic or symptomatic. Symptomatic must give the treatment. Asymptomatic, no need to treat that patient because patient is asymptomatic. You never know. He's an athlete. You did not ask the history what he's doing. He's so told, I am a marathon runner for 10 years. Those who are marathon runner, they have parasympathetic overactivity and it physiologically reduce the parasympathetic, reduce sympathetic, increase the heart rate, bradycardia, right? So you don't need to do, right? It's an athlete and it's a physiological, that's it. But whenever there is a bradycardia or tachycardia, let me tell you, either brady or tachycardia, first and foremost, as Dr. Sonika told, do the ECG. Try to find out any abnormalities there or not. If it is not there, right, everything is normal sinus rhythm. When there is a bradycardia, but normal sinus rhythm, you don't need to treat. You don't need to treat. You don't need to treat. Right? If they have something abnormality, then you think of doing this. And when they have abnormality, they must have some symptoms. They are not asymptomatic. And when there is a symptoms, irrespective of the cause, you need to treat. You need to treat whether beta blocker, low bradycardia, same patient, you give atropine, right? If sick sinus syndrome, you give beta blocker. If the sinus bradycardia, you give atropine, right? Or any symptomatic bradycardia should be treated with atropine. That's it, right? Amiodarone, let's go with the other drugs. Amiodarone is drug usually, right? Is an antiarrhythmic drug used in BLS, ACLS protocol, right? Atropine, metoprolol is beta blocker. So if you give beta blocker to this patient, 48 will go it to 28, and patient has high risk of death because already patients counts are low, right? Or patients heart rates are low, and you are giving on top of this. So that's all from my side from these questions. But let's have a look very quickly the mental status and hypoperfusion in elderly patient, most likely sick sinus syndrome. It could be MI. Always keep in mind lots of drugs which can cause atropine is the drug of choice for symptomatic bradycardia. Adenosine is not a part of bradyarrhythmia or bradycardia algorithm. It is used mainly for the atrioventricular nodal re-entry tachycardia. Look at the ECG lecture of Dr. Maddy on YouTube, our channel. Wolf Parkinsonian White. So just remember WPW syndrome. And second important thing is when we do the vagal maneuver and it gets failed, right? Vagal maneuver, it gets failed. You can use the adenosine. Amiodarone again, it's not part of this bradycardia algorithm. It's a class 3 antiarrhythmic drug used for wide complex tachycardia, not bradycardia. And isoproterenol is a part of the advanced cardiac life support bradycardia algorithm. It is not a first line agent, so it's not obviously cannot be used before atropine. And metoprolol worsen the things rather than improving the things because pulse rates are already low and you are trying to get low. So it's not a good idea. So that's it for one questions. Those who don't know the shock, go and read. Write down in your notes. Write down in your notes everything. Shock, read completely. 100% it will come, right? Irrespective of your exam, DHA, HAD, MOH, right? Even pediatric surgery, medicine, gynec, basic things they will ask in all exam. Even if you're gynecologist, they ask. Even if you pediatric, they ask. Even if you internal medicine, they ask, right? So basic is basic, right? So you must know this, right? So shock completely, you must know. There is no excuse of not knowing the shock. Absolutely high yield topic for any exams, right? Second questions in front of your screen. 3 years old patient with the sickle cell anemia is brought to the emergency department complaining of pain in his lower arms for 3 days. On physical examination, both arms are swollen, tender, erythematous, is febrile and complain of chills, leukocytosis on the blood counts with prominent neutrophilia. Which of the following is the most appropriate treatment? So you can start thinking of now. I'm not in hurry, right? Before jumping on the treatment, they are asking the treatment. So before the treatment, you need to know what is the diagnosis. Without diagnosis, how you gonna treat any patient? Tell me. And how you investigate and then treatment. But they are directly asking you. So here you need to do two things. You need to diagnose first this case, what the patient is suffering from, and then you need to tell the answer, real answer of this question. That is a treatment. What they ask in exam is the treatment. Yes, post the answer in the chat box. Read it well, no problem. We are not in hurry. This is learning platform. Yes, Dr. Javeri, any comment? Yes, any comment, Dr. Javeri? We are more than 30 doctors in the class.
Mm, I don't know, sir. I'm just reading right now.
Okay, take your time, not in hurry. Take your time. Think that this all question comes in exam, how you gonna respond? Dr. Santosh, what's your Santosh Podel? What's your comment on this, sir? If you are in the class, you can interact. Yes, Dr. PHC Kalhangara.
Sir, C, antibiotic.
Sorry, doctor. What's your answer? Yes, you go ahead. Whatever in your mind, you go ahead. No problem. Yes, anyone.
Fever with chills, it is showing no, sir, leukocyte count is high. So it is
Fair enough.
like
So what's
it
the
is
diagnosis?
showing
My
sepsis.
simple question, first question, simple is what's the diagnosis in this patient? You need to make some diagnosis. Any patient, any MCQ. I told you the basic first before starting lecture. This is MCQ. We need to know the three things: diagnosis, investigation, and treatment. Here they are asking the treatment, but how are you gonna go for the treatment without diagnosis? This is the practice everyone must do from today onward.
It's an
Just mugging
infection,
up.
infection related
Okay, so infection.
condition.
You are absolutely right. Infection. Now I'll ask you a second question. Where is the infection? You read the question. If I break the questions, things are so easy. Oh, it's very easy, sir. You need to apply your all practical knowledge and theory knowledge. You see now where is the problem? Where it could be. You read the question. Everything is in question. Infection, 100% infection. Why? When there is a when there is a leukocytosis, you think of infection. When there is a
Infection is
fever or
in the heart,
febrile,
sir.
so fever and high
Sickle
count is
cell
infection.
crisis.
Sickle cell crisis. So one answer is sickle cell crisis. Again, asking you when there is a tender joint, when there is a tenderness, when there is a erythema in the joint, patient has a leukocytosis, right? What could be the things? Where could be the infection? In the lung,
Bone
in the
infection,
bone,
sir.
in the
Long
urine?
bone
Where is the
infection.
infection?
Bone,
Bones, bone marrow,
Bone.
bones.
So bone. When there is a infection in the bone, what you call that?
osteomyelitis.
Myelitis.
Excellent. Osteomyelitis. So this patient, so diagnosis finally is a this is a sickle cell crisis or sickle cell disease with recent presentation of osteomyelitis. Is that clear? Because they had given the diagnosis already they had given. You don't need to mug up. Sickle cell anemia. First line, if you see their 3 years old child presented with sickle cell anemia. So they had given you this known case of sickle cell. Now, what is the problem in sickle cell anemia? Now he brought to the emergency for pain in lower arms, 3 days, physical examination, right? This is all signs of inflammation in physiology, right? Pain, tenderness, redness, loss of sensation, isn't it? I think we forget the physiology. So this is a signs of inflammation, right? Or infection, right? So infection in eventually lead inflammation. So joint inflammation, osteomyelitis, right? So this is a sickle cell disease with osteomyelitis. Now they are asking for the treatment. So what you gonna treat this patient? What you want to give from this selected options? Calcitonin, ceftriaxone, ciprofloxacin, erythrodronate, vitamin D. What you want to give to this patient? This
Ceftriaxone.
patient,
Ceftriaxone, sir.
obviously, I mean, pain and hydration and pain analgesic is absolutely its answer. But in
Analgesics,
context
sir.
to these questions, what you gonna prefer? Those patients who are sickle cell and in crisis or in septicemia or in a osteomyelitis suspected case, what antibiotic or what you will give and what you will do? Tell me. Anyone open one volunteer for the discussion?
Actually, I'd like to go with ceftriaxone, sir. Because
Ceftriaxone. Okay, fine. Fair enough. So now tell me, ceftriaxone is what? Which generation antibiotic?
usually the causative organism for osteomyelitis in sickle cell is the Staph aureus, so it covers both gram positive. So we like to
It
go with
covers gram positive or it also cover gram negative as
yeah,
well.
negative.
Ceftriaxone.
It covers both, sir.
I'm just
Gram
trying to
positive.
understand your concept. My simple question, brother, is that is is ceftriaxone covers gram positive, gram negative, both or what?
It covers
This
gram
is
positive.
exam questions, recent exam questions. Okay,
I
gram
think
positive
It
only.
only covers gram
Gram
positive.
positive, sir.
positive. Gram
Gram
positive.
positive.
It covers only gram positive. So ceftriaxone will not cover the gram negative. Yes or no?
Causative organism for osteomyelitis might be gram positive. So the like in this all options given, ceftriaxone is the most appropriate one.
Fair enough. Fair enough. Answer is ceftriaxone. You are absolutely right. Now I want to understand the concept, right? How many types of this cephalosporin or what is this drug, right? Penicillin or cephalosporin?
It is the third generation cephalosporins.
Cephalosporin.
Cephalosporins.
Cephalosporin.
4 to
Give me
5
the one.
students.
Give me the one name of all cephalosporin group. First generation, second, third, fourth. And tell me first of all, ceftriaxone is in which group?
Third generation IV cephalosporins.
Huh? Third generation
Third generation.
ceftriaxone. Wonderful.
Third
Third
generation.
generation. Correct. First, second, third, fourth. Tell me. Anyone can do it. First is
Cefazolin.
one person can speak so I can understand.
Cefazolin.
Cefazolin. It's a first generation.
Yes.
Yes, it's a okay. So cefazolin. Yes, it's a first generation. Cefazolin. The most common what we used in India is a cefadroxil. Somebody if know cefadroxil. Cefadroxil is also there are long list, at least 10 drugs, but I'm just trying to make you understand. Right? Second generation, anybody second generation, only one name. I'm not asking you 10 names.
Cefuroxime.
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 Right, cefuroxime, cefaclor, cefuroxime.
Cefuroxime.
Third generation is ceftriaxone, as we already discussed. Only one name I need. Fourth generation,
Cefapime.
excellent, cefipime, brilliant. And fifth generation,
Ceftarolin.
excellent, ceftaroline.
So due
Now,
to
why there
you,
is
I remember all.
wonderful. Thank you very much, sir. So this is all this drug, five drug. First generation, I mean, second is better than first. Third is better than second. Fourth is better than third, and fifth is better than fourth. Here, the first and second generation, in general, they cover more gram positive. Third, fourth, fifth, they usually cover gram negative. They covers lots of, but just general understanding I'm giving you, right? So any antibiotic, the main concept of any antibiotic, any group, any agent, start with the lower dose and start with the initial drug. If no response, then you can escalate. You can directly, if somebody is with the upper respiratory tract infection, directly you cannot go give ceftaroline. You can't give. It makes resistance. Start with the cefadroxil, right? Cefazolin. If no response, then you go for this, right? So even you can give the ceftaroline to this patient of sickle cell with osteomyelitis. Why we selected ceftriaxone, right? It covers both. Just for your knowledge, go and read it. It covers gram positive, gram negative, both. Go and read it, right? So second homework. First homework is shock, right? Everybody in your note, complete shock you have to read. Second homework is a cephalosporin. What are the five generation of cephalosporin? Why these generations are there? Why first is better than second? What all cephalosporin covers? What I'm talking and teaching you about, right? And which antibiotic is available oral versus IV? Is cefadroxil is oral or IV? Is ceftriaxone is oral or IV? You just know the basic. You are a clinician, right? Exam passing is different thing, but being a clinician, you must know little basic things as well, right? So this is second homework. So here in this context, right, there are five generation, and each generation, if you go more to the generation, it's more stronger antibiotic, right? And you start with the lower and go to the higher, right, as needed clinically. Depends on the culture sensitivity and clinical context of the patient, right? So this is what the thing is. One another questions very frequently asked in exam. Which are the antibiotic which active against MRSA? There are two staphylococcus, methicillin sensitive. Let me add one page in this discussion. So methicillin sensitive and methicillin resistance. Have you heard of this methicillin sensitive and methicillin resistant? So staphylococcus, right? Staphylococcus. Yes. So staphylococcus. So methicillin resistant Staphylococcus aureus, methicillin sensitive Staphylococcus aureus. Can you tell me the name? This is not dangerous and ask very frequent questions in exam. What is the drug of choice for methicillin resistant Staphylococcus aureus?
Vancomycin.
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 Penicillin.
No, give me the specific drug name, like vancomycin is the drug of name. You can tell aminoglycoside, but it's a huge range. So give me the drug name specific. One is vancomycin. What else?
Linezolid.
Vancomycin, if a patient is a hypersensitivity to vancomycin, then what you gonna use?
Penicillin.
Penicillin, ampicillin.
So say for example, you have a severe septicemia with MRSA positive. What drug you use? This is exam question in HAD and DHA and MOH. So write down the list, doctor. This is extremely important. Whenever there is a severe infection, it is again a Dr. Guru. Have you seen in your ICU MRSA problem? Can you share little quick experience, 1 minute, half minute? How much the MRSA common in your ICU? So vancomycin is drug, one drug. Second drug is linezolid. Write down. You just need to remember this. If the question comes in exam, right, they may ask you, no, vancomycin patient is highly sensitive, hypersensitive to vancomycin. Then you can't just remember one name. Second is a linezolid. Third is a daptomycin, DAPTO, daptomycin. Fourth is a TG cycline. And only cephalosporin which covers MRSA is a ceftaroline, as we recently seen. This is ICU critical patients. If I say it's a minor infection, it's a simple infection, it's a outpatient or OPD patients with MRSA patient is absolutely fine, not in ICU, right? What are the options? What are the options? Anyone? If you don't know, write down Bactrim, that is sulfamethoxazole and trimethoprim, clindamycin. Write down or take a picture of this clindamycin, and third is the doxycycline. So these
Sir,
are the
linezolid also?
questions. Linezolid is also, yes,
Yeah,
linezolid
oral
oral
form is
available.
available.
Yes,
Yes.
yes, you are right. Right. So whatever the oral available and IV, you can use both, but in general. So take a picture. Remember, this specific question 100% they ask in every other exams. MRSA, methicillin resistant Staphylococcus aureus. That's it. Right. Another credit questions. Right. Which first generation cephalosporin? Right. And methicillin sensitive, right? Oral and IV. Take a picture. I think little complex, but it's very important for exam, right? So if they ask you oral or oral option is there are two options: dicloxacillin and nafcillin. These are the first generation, right? IV, oh sorry, oral, first generation oral. Sorry, my mistake. Oral first generation. So if somebody asks you methicillin sensitive Staphylococcus aureus, oral options are dicloxacillin and cephalexin. Oral, huh? And IV, there are two options: oxacillin and nafcillin. So your staphylococcal chapter is over now. This is high yield point in the exam. Staphylococcus, two options: methicillin resistant, methicillin sensitive. Methicillin sensitive, two options: oral which, IV which, oral dicloxacillin, cephalosporin, and here the oxacillin and nafcillin. ICU patients, these are the five common options. You start with the vancomycin is always the first answer. If not responding, then you can escalate as I told you, right? And here in a minor, you can use this. That's it. Is that clear to everyone? At least tell me yes or no.
Yes, sir.
Yes, sir.
Yes,
Is
sir.
that
Yes,
clear to
sir.
everyone? Yes or no?
Yes, sir.
So we don't need to just mug up. We need to understand what is these things. Now we reach to the answer. We reached the answer. is a ceftriaxone. Now I posted the 5 more questions which all pertaining and important for the exam point of view. So here the diagnosis, our first step is sickle cell disease or sickle cell anemia with osteomyelitis. Drug of choice is a ceftriaxone, which is a third generation. This is how you have to prepare in your exam. This is third generation cephalosporin. Third generation cover what? Gram negative, gram positive, negative what, and what is the side effect of this drug. This is how you have to prepare after my lecture. You don't just need to remember, because they may ask you some different questions of MRSA, right? So I can't cover everything in one, right? That is why we usually recommend people to join the coaching. This is the reason, because this is absolutely concept based. No, once your concepts are clear, whatever they ask, you don't mind. I don't mind seeing any patients in my hematology practice, because I have options. No? I have concepts clear. If the patient comes to me with anemia, how to approach? I know how to approach thrombocytopenia, how to approach pancytopenia. That's it. Anyway, so how to diagnose sickle cell disease? What is the name of the test by which you diagnose any patient as a sickle cell disease or anemia? Give me the only one name clinically used frequently to diagnose sickle cell anemia. Anyone open? This is applicable to pediatrician, physician, gynec, GP, internal medicine, because sickle cell is everywhere, and especially in Middle East, it is too much. So no answer, nobody. Yes, Dr. Sonika, so you mentioned HPLC. So what is HPLC?
Hemoglobin electrophoresis.
Hemoglobin electrophoresis. Okay, so how
No.
you differentiate? HPLC is a method basically, right?
Yes,
But the
it
test name
is.
is
Yeah,
hemoglobin electrophoresis by HPLC. So HPLC is a method.
yeah.
How you use? Fine. So how you differentiate sickle cell disease and sickle cell trait? Second,
Peripheral smear, sir.
sickle cell trait and sickle cell disease slash anemia. What is the differentiating point? 8 to 8 comparison. Tell me.
Hello.
Yes, I am
In
audible. You are audible.
Sir, peripheral smear we can differentiate.
Peripheral smear. So how peripheral smear? So I'll draw the peripheral smear. This is my hardcore subject of hematology. So I love it. This is RBC normal,
So if
right?
sickling is present,
One second, one second. Peripheral smear, this is normal, where the RBCs look like a biconcave or dumbbell shape. This is classical, dumbbell shape or biconcave. In sickle cell, you see the sickle shape RBC. This is sickle shape. This is sickle shape. Right? Just for your knowledge. So you can see in trait, you can see sickle, in disease, you can sickle. Then how you differentiate that this is a peripheral smear? Because in trait, you see sickle, in disease or anemia, you will still see the sickle under microscope. Then what is the advantage of doing the hemoglobin electrophoresis? You just see the peripheral smear and tell, okay, this is disease, this is trait. Now tell me, now your explanation.
I don't remember.
in sickle's cell trait, it's inherited the one gene for normal hemoglobin and the one for the sickle hemoglobin. And in sickle cell disease, two genes inherited the for sickle hemoglobin from the parents.
Which gene? Do you know the name of gene? Where is the problem in the chromosome in sickle cell disease? Which chromosomes gets affected in sickle cell?
Beat there is a mutation in the beta glutamine chain. That's the number.
So which gene or aminoglycoside replaced with wheat, or what is missing, or what is the exact pathology? If you don't know, go and read it. Anyway, just to save the time. Fine, fair enough. So,
So glutamic acid substitute with
So first,
hypoxic.
as doctor rightly said, there is a one sickle gene is there, and in disease there is a double S. This is S normal, this is SS sickle, right? The another important whether, right? So sickle cell trait and sickle cell disease, the main thing is this is a minor problem, this is a major problem, right? Both is a problem obviously, but this is minor, this is major. right? Here in sickle cell trait, the most important thing is HbS, sickle hemoglobin S. We'll take in hematology lecture. Probably send me your feedback, what you want me to deliver you, right? Especially, so I'll go through it and I'll make a notes accordingly, right? Because I don't know who wants what. So I'm in general, I discuss the high yield point. So HbS is usually less than 40%. This is the most important high yield point for you to remember. And here usually more than 40%. It could be up to 90, 100% as well. Disease, right? So it's a more severe problem, right? More the sickle in the peripherals, more the sickle in the blood, more the problem. Less the sickle, less problem. Simple, right? So if somebody has a 5% sickle, out of 100 RBC, 5 RBC sickle, and somebody out of 150 RBC is problem, this is severe problem. This is a mild problem. Both are problem, but this is mild severe. You need to understand. Sickle cell trait, usually no treatment. Sickle cell disease, you need to treat the patient. Treatment is a transfusion in case of emergency. Treat the infection if it is there, and only curative treatment. Anybody knows the answer? If I want to ask you, what is the only curative treatment options across the globe for sickle cell disease? No option. If you want to cure forever, now you are not no more sickle, you are normal. What's the treatment?
The bone transplantation.
Excellent, wonderful. So better word is bone marrow transplant, not the bone transplant. Bone marrow transplant. You are not replacing bone to bone, you are replacing marrow to marrow. Is that clear?
Yeah.
From one person to another person, from healthy to sickle cell. So healthy individual gives bone marrow to sickle cell disease, it could be a healthy again, right? So indication of bone marrow transplant, again not going in detail. Commonest is sickle cell disease and thalassemia major.
Thalassemia.
Yes, so I did my fellowship in Italy, Rome for a few months. For this is considered as the biggest transplant center in the world, right? So fortunate enough to get a training in transplant in Italy, Rome. So I come across many indication there in Italy, but they are transplanting sickle cell disease and thalassemia with excellent result, excellent, right? And there is a long list of indication. I can say 10 minimum. So hemoglobinopathies, these are the two major. Then refractory leukemias, lymphoma, multiple myeloma, aplastic anemia, myelodysplastic syndrome, right? Blah blah, long list. Anyway, so these are the few common one which you need to know, right? So this question is answered very well by Dr. This sickle cell disease. The diagnostic test usually is a initial test. If they ask you the initial test, sickle cell, so CBC and peripheral smear is a initial test. Diagnostic test is a diagnostic test is a hemoglobin electrophoresis, and one of the most accurate test is a genetic test, right? But at least you should know this, right? We don't get into the complexity for a GP doctor, but initial and diagnostic you must know. Commonest organism associated with the sickle cell disease and osteoarthritis. Yes, Santosh. Now I think you play a role, right? So what do you think? Specific answer for this commonest organism, especially for osteoarthritis with sickle cell disease. What's the name of the organism?
Staph aureus.
Sorry.
Staph aureus.
Staph aureus. Okay. One another is there, but anyway, fine. Common antibiotic you used in such patients of osteoarthritis with Staph aureus?
Third generation cephalosporin. Zone. Ceftriaxone.
Ceftriaxone. So that is also covered, ceftriaxone. Fourth question in exam they ask very frequently, which vaccine to give prior to the splenectomy and when to give?
Pneumococcal vaccine.
Pneumococcal vaccine.
Pneumococcal.
HIV.
Pneumococcal. Pneumococcal. Only one pneumococcal. So those patient, I mean, going splenectomy. So asplenia. Let that I read this chapter, interesting chapter yesterday. Asplenia means no spleen. Either anatomically, since birth it is not there, and one is a functional asplenia. So in sickle cell disease there is a functional. At the time of birth spleen is there, but because of chronic sickling in the splenic pulp, spleen gets destroyed, and the word written in the book is autosplenectomy. Have you heard this word, autosplenectomy? So spleen is no more working, either congenitally absent, that is asplenia. Spleen is there, but it is not functioning at all. So functional or anatomical asplenia, right? So asplenia means has no spleen, right? So has no spleen. So there are three organism, right? Pneumococcal, meningococcal, and Neisseria meningitidis. These are the three vaccines you must give encapsulated organism. What happens when they go into the spleen, right? When they go into the spleen, it will destroy the spleen. But when spleen is removed, this encapsulated organism will not get control, and there is a severe sepsis and patient may die. And that is why people are concerned about doing the splenectomy, right? And what happens after splenectomy? I'll tell you very quickly in 1 minute, right? So this is what the vaccine needs to be given. Can anyone has any idea when to do? If some patient has a sickle cell disease, right, and the plan surgery, right, there are two type of splenectomy: plan splenectomy, emergency splenectomy. Emergency when there is a road traffic accident, car to car collision, spleen is absolutely ruptured, you need to remove, you have no time, massive bleeding from splenic vessel, you need to do the splenic removal, and you need to ligate the vessel. But when there is a plan, say for example, after 1 month, doctor is saying we'll do your splenectomy after 1 month. In that case, you need to give this vaccine. And when you supposed to give this vaccine? After surgery, before surgery, at the time of surgery, or what time frame?
The 3 months before surgery.
3 months before surgery. Why 3 months? Why not 1 month? Anyway, I'm happy at least you are interacting. So usually it should be given before 4 weeks,
2 to
right?
4 weeks before
Get the
surgery.
so just to get the immunity, right? So that is also important. Do you know any drug which can prevent the sickle crisis? So patient has a sickle cell disease. Do you have any drug which can help patient to delay the crisis, or there is no crisis if you use that drug?
Hydroxyurea.
Wonderful, wonderful, wonderful. Hydroxyurea. Hydroxyurea is the drug of choice which prevents the three, four things. It reduces the transfusion requirement. It reduces the hospitalization. It reduces the sickle cell crisis and death as well. And it will not act on the sickle gene. It will act on the hemoglobin F. It will not act on the HbS. It increases the HbF, just for your knowledge, just for your knowledge, right? So there are four types of normal hemoglobin in hemoglobin electrophoresis in normal person: hemoglobin A, hemoglobin A2, and hemoglobin F. There is no HbS in normal individual like you and me. There is 0% hemoglobin S. Zero. In adult, A is around 98%, A2 is 2 to 5%, F is less than 2%. This is normal range, just for your knowledge. We'll cover sometime in absolute hematology lecture. But anyway, so it should be given. And to prevent the crisis, hydroxyurea will not act on HbS, it acts on HbF. It increases the HbF, so sickling will go down. And what are the hematological changes in post splenectomy patient? So if somebody, you did a patient's splenectomy, you did it, is there any change in a CBC? Do you see any change in CBC? Do you change anything in a peripheral smear? Do you see some kind of complication post splenectomy?
Sir,
Anyone?
in peripheral isthmus, we will see Howell, mm, so Howell jolly bodies we will find.
Excellent. Howell jolly bodies. So any patients, asplenia, functional or anatomical, if they have a Howell jolly body, right? So if doctor, you can also answer, if the Howell jolly body is seen, right, it is until proved otherwise, it is considered that this patient is a splenectomized patient. But still you see the Howell jolly body, then what could be the diagnosis? You did a splenectomy, right? Howell jolly body should be seen, but there is no Howell jolly body seen in peripheral smear. Then it must be a accessory spleen. Accessory spleen. Is that clear? Yes or no? Tell me at least yes or no.
Yes.
In
So
CBC,
explain the last point, please, sir. If we don't see Howell Jolly bodies.
then there must be another spleen. One spleen is there, but there must be a small rudimentary or accessory spleen.
Okay, sir.
Got it?
Thank you.
Right. So so there is a leukocytosis can see increased neutrophilia, increased lymphocyte, increased platelet. These are the things which you can see. So ITP patients, I am doing this every day, 50,000 platelet patients, and one of the treatment of ITP after steroid is a splenectomy, and after splenectomy, this will increase from 50,000 to 250,000. So there is a thrombocytosis. So thrombocytosis, platelet increase, right? And risk of this again is one of the risk is thrombosis. Any patient has a thrombosis, usually after splenectomy in high risk patient, either you give 4 weeks of heparin or you can give second option. First is heparin for sure. Second option is aspirin as a prophylaxis for 4 weeks post surgery. So these all are the little important questions in context with the sickle cell. So third homework is to go and read the sickle cell disease, sickle cell anemia trait versus measure, how you interpret in hemoglobin electrophoresis, blah blah, everything I told you. So Dr. Santosh, two organisms, Staphylococcus aureus and Salmonella paratyphi. So, in patient with a sickle cell anemia, the primary agents of osteomyelitis are Staph aureus plus Staph paratyphi, Salmonella typhi. Osteomyelitis is most common complication of sickle cell disease crisis and may stop blood for the portion of the blood and bone gets infected. A third generation cephalosporin such as ceftriaxone is an acceptable choice, and any antibiotic regimen needs to cover both the organism. This is the best, easiest, cheapest, and widely used across the globe. Right, so very important slide for you guys. I got it from another international journal today, and I try to catch up here for you better understanding. Asplenia means three word, right? Asplenia means right.
No
So
spleen.
yeah, no spleen. H influenza, Neisseria meningitidis, right? So asplenia means has no spleen. Three words, has no spleen. Asplenia means he has no spleen, right? And this HNS is a vaccine name. H means H influenza, easy to remember. Neisseria meningitidis and Streptococcus pneumoniae. Asplenia means has no spleen. Person has no spleen means asplenia. And this HNS stand for the abbreviation H influenza, Neisseria meningitidis, Staphylococcus or strep pneumoniae. Is that clear? Little easy. Yes or no?
Yes, sir.
Yes or no?
Yes, sir.
Wonderful,
Yes, sir.
wonderful. And hematological changes in asplenia, as I told you, Howell Jolly bodies is seen if you and a lack of Howell Jolly on peripheral smear in a splenic patient indicate accessory spleen. I told you. Target cell you can see like iron deficiency, lymphocytosis, neutrophilia, right? And thrombocytosis, as I already told you. And another thing I missed is it also decreases the immunoglobulin IgG, IgM, so immunity is reduced, and that is why the antibiotic prophylaxis coverage and all blah blah is required for these patients. So let's jump to the next important questions. Bear with me for a few more minutes. 32-year-old college student. So read this sickle cell chapter, third homework. You write down in your notes. 100% question will come in your exam. 22-year-old college student present to the student health center because of 10 days history of headache, malaise, myalgia, sore throat, and low-grade fever. He also complains of non-productive dry cough for past 7 days. X-ray of the chest show peribronchial infiltrates. Which of the following is most empiric treatment for this patient? Amoxicillin, azithromycin, ceftriaxone, penicillin. What's the diagnosis and then treatment? Take your time. Take your time. Not in hurry. Yes, Sonika, any comment?
Mm. So it is a respiratory tract infection, and
What's the
it
diagnosis? Can you name the respiratory, upper respiratory, lower respiratory, name of the disease, pharyngitis, pneumonia, whatever, blah blah.
so
Respiratory
it
is
is
long.
pharyngitis. Yes,
It, it is
sore
pharyngitis.
throat.
Okay.
The patient has
So do
sore
you think
throat.
in pharyngitis there is a bronchial infiltrates?
No, sir. No, 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 no.
Then what's the
Then it is
diagnosis?
LRTI.
Yeah, absolutely. LRTI. You are absolutely
Hmm.
right. Going well. Need to boost up the confidence. Wonderful. So LRTI. Can I tell it little bit more? Common word is pneumonia.
Yes, sir. Yes, sir.
Fine.
So
So
since the patient has just low-grade fever, we do not need to start on IV injectables. But had it been uh, had the patient had like worse symptoms, we would have put the patient on injectables like ceftriaxone we could have given. But
fair
since
enough.
it's low
So
grade, is it through?
fair enough. Fair enough. As you throw. Now let me ask you: are you comfortable if I ask you a question? Are you okay?
Yes, sir. Yes.
Wonderful. How you define? How you define typical pneumonia versus atypical pneumonia? Have you heard of this word or not heard in your practice?
So yes, I have heard, but I don't remember as of now.
No problem.
Like
That is why we are here, na doctor.
yes, sir.
I'm here to remind you everything. You all are brilliant, I know, but you need to brush up. That's it. And that is
Yes,
why I'm
sir.
here. Yes. So anybody wants to try this? What is typical? What is atypical? 4, 5 important points are there which you need to clarify. Pneumonia is a leading cause of morbidity and mortality across the globe, not in Middle East, across the globe. 1 in 10, 10 in 1, right? So die, right, of pneumonia across the globe. So you must know. Na? COVID-19 is what? It's atypical pneumonia. COVID-19, we everybody experienced across the globe, millions of lives gone, right, because of this pneumonia only, right? Near and dear we lost, right, in pneumonia. So anyone, Dr. Javeria, do you have any idea how you differentiate this?
Yes, sir. Atypical is non-bacterial and typical is bacterial pneumonia.
Okay, so atypical is non. You mean to say if there is
Non-bacterial.
a so non-bacterial is atypical, right?
Yes, sir.
And bacterial is typical,
Yes, sir.
but it is not. Even right, bacteria also can cause atypical. This is the only one difference in the whole house. Nobody knows. Simple questions.
Typical
How
is
you
caused by
differentiate
some
typical?
particular bacteria. Streptococcus
Sonika.
pneumoniae, Haemophilus, Staphylococcus.
Fine. So this is the so one what I understood from your thing is a organism. Organism
Organ.
may differentiate typical versus atypical. Okay, fine. We'll see which organism. Second questions. What are the presentation in both the things? Is there the same presentation in typical and atypical?
Typical with fever and productive cough.
And how is the cough in both the things?
Productive.
What is the time
Productive cough.
frame within time frame? What time frame you usually think productive versus non-productive? These are the all basic questions of typical versus atypical. If you know this, then you can differentiate. Anyone wants to try? Kalhagra, you posted URI. Yes. Any comment from you?
Sir, in typical, we will have productive cough. Atypical, it is sore throat type.
Okay, fine. So cough, I can say here you typical is productive cough. I can say here
Hmm.
non-productive cough. In general, just understanding. Okay, fair enough. What else?
Fever with chills, we will have, sir, in typical pneumonia.
Okay. Yes, Jamila. Any comment, Jamila? Yes, Dr. Sabah Khan,
Yes.
any comment? Yes, anyone.
For the atypical pneumonia, the onset is insidious. Fever is not very high. It's usually mild to moderate. And then the organisms that cause the pneumonia differ from that of the typical pneumonia.
Okay. 1 second, please hold on. 1 second. હા બોલ હા હા વાંધો નહીં આપણે 2 અઢી વાગે મળીએ. Yes. So basically, let me give you the complete clarity of typical versus atypical. This is excellent chart. Either you can take a picture or you can see the videos again for better clarity. This is a simple but important, very important chart. Let me clear everything. Yes. So typical pneumonia and atypical. So first of all, onset. Typical is usually acute. Usually acute, typical. This is gradual, usually more days. History, if you see 4 days, 5 days, 6 days, 7 days, this is usually in 1 or 2 days. Patients suddenly develop this. So this is little time frame. Typical, any age they can develop acute, right? This is usually in an older child or adult. Fever is more striking here, is a high grade fever, right? And here usually low grade, 99, 100, like this. They are usually high grade fever, 102, 103, 104 Fahrenheit, like that. Cough is usually productive, here usually non-productive or dry cough, right? Chest x-ray, in typical you have a localized, this is extremely important on the chest x-ray finding, right? And this is COVID. Remember, COVID is atypical, right? Diffuse, right? So this is chest x-ray, right? You have diffuse, upper, middle, lower infiltrates. Here localized, right? This is lung, right? You have just upper lobe infiltrate. That's it. Rest of the all lungs are normal, right and left. Localized. This is diffuse. Organism common. Streptococcus pneumoniae is common. Here mycoplasma is common. And here atypical, usually macroloid, and macroloid is a azithromycin. Azithromycin is a macrolide. What we used in millions of people in COVID is atypical pneumonia. We used a lot azithromycin, 500 milligram once a day for 3 to 5 days, depends on the symptoms, can extend to 7 days or more. And here typical ceftriaxone, again third generation cephalosporin or any broad spectrum, but you start with the ceftriaxone. You can escalate as per the need of the patient. So I think I don't get easier than this chart. What do you think? Yes or no? Yes or no? At least tell me yes or no.
Sir.
Yes, sir. Yes.
Yeah. So this
Any
is
point
most
for
easiest.
resolution?
Sorry, ma'am.
Any point for resolution? Like faster resolution in typical or atypical pneumonia, that cannot be a point.
Not really. Not really. Not really. Right? It depends on the stage, severity, and CUPS 65. Right? If you have community acquired pneumonia, remember this homework: community acquired pneumonia, hospital acquired pneumonia, and ventilator associated pneumonia. Again, there are in pneumonia what you need to know. Right? First, I told you, first thing in pneumonia, you need to know typical versus atypical. This is one thing I already told you. Second is how you differentiate. Second thing, various pneumonia. Third thing, what is CURB 65? CURB, confusion, uremia, respiratory rate, blood pressure, age is 65. What is the CURB 65? And what is the importance of CURB 65, right? And what are the organisms commonly associated with the pneumonia? Especially in child, it's little different. Adult, it's different. This all questions comes in exam, believe me. And then treatment, obviously, right? Simple. So these are the things which you need to know. One of them is typical versus atypical. So I just need to give you the concept how you differentiate in your clinical practice. And these are the organisms as well. So here again, the typical versus atypical, if you're going to go for the list. Typical, right? Streptococcus pneumoniae, most common, H. influenzae. And here atypical, long list. Mycoplasma, as I told you in one line. Mycoplasma pneumoniae, chlamydophilia, right? Legionella, TB, tuberculosis, viral, like COVID-19 is a virus, right? COVID-19 is a virus, and fungal, aspergillus, candida, blah, blah. This is all atypical. Usually see in immunocompromised patients, HIV patients, right? Organ transplant patients, right? Chronic uncontrolled diabetic patients, on steroid patients, or some autoimmune disease, blah, blah, right? So these are the patients who are more vulnerable to get the fungal infection. As here, typical sudden onset less than 2 days, usually with fever, productive cough, right? Here, usually dry cough. Diagnosis, right? A gram stain useful. Why? Because you can easily identify on gram stain. They are little difficult. Why? Because they have no cell wall. Usually, this organism atypical, right? Here, the localized lobar infiltrate. This is diffuse interstitial infiltrate. They are usually sensitive to penicillin. They are not. That's all from my side for the basic concept of this things. I have a lot more things to tell you in pneumonia. So here, for the sake of the answer is macrolide, as Dr. rightly told, Dr. Sonika, right? Azithromycin. Why? Because azithromycin is a covering atypical, which other amoxicillin not cover atypical, ceftriaxone. And remember, usually in typical, you cannot see headache, you cannot see malaise, you cannot see malaise, myalgia, you cannot see the sore throat, and patient has low grade, right? In typical, high grade. So everything is matching, and this is what the picture I got it for atypical pneumonia, especially from another journal. Atypical pneumonia typically has an indolent course or slow onset, and commonly manifest as a with extra pulmonary symptoms also. Non-productive cough, our patient has non-productive cough. Dyspnea, yes, also, there is a common extra pulmonary features. Fatigue, our patient has. Headache, our patient has. Sore throat, our patient has. Myalgia, malaise, our patient has. So this is atypical pneumonia. And this is last important slide. I got it from another journal. Does the classification of atypical impact the patient's management? Is it mandatory to do whether it is typical or atypical? Sir, anyway, we are going to give the antibiotic. What is there? Why we break our head for typical, atypical, blah, blah, blah. So the important is the classification of atypical pneumonia does not have a major impact on the patient's management, because it is now always not always possible to clearly distinguish between typical and atypical. So it's easy by me to tell you in a theoretical way, oh, this is typical, this is atypical. But when it comes to the clinical practice, when patient has a fever, myalgia, headache, cough, productive cough, confusing history, patient has occasional, I have productive cough, what to do? Occasional I have product. I have low grade fever, but sometime I have high grade fever. What to do? You understand? So it's little sometimes difficult, but you need to judge the clinical judgment. But also you need to keep this slide in your mind, that what it's gonna tell you, what's the exact thing, right? They wants to tell. So if you have the clarity, you can answer the questions very well, right? So let's take one more questions if you are comfortable. Should I go for one or two questions, or
Yes, sir.
okay? Let's
Yes,
get
sir.
couple of more questions. Patient with iron deficiency anemia is being started on a treatment with oral ferrous sulfate. Which amongst the following is the earliest indicator of response to oral iron therapy? So it's a very simple, straightforward question. Some gentleman has iron deficiency anemia. You started the oral sulfate or oral ferrous sulfate, right? Now you want to know that patient is responding to oral iron, right? And they are asking earliest indicator. What is the earliest indicator amongst this which can be used practically in the clinical practice, right? So let me clear all the drawing. Fine. So what is the earliest indicator of response to the oral therapy? Tell me. Increase in the hemoglobin is the earliest thing. So say for example, patient has a 8 grams of hemoglobin. You started oral iron, iron started. Now you want to see the response, that my oral iron is working well. So what do you think? Hemoglobin will increase first, reticulocyte count, or normalization of ferritin, or increase MCV. What? How? I mean, you assess the response. Common but important. Yes, Noah.
So, I think the iron uptake will be increased by binding it with serum ferritin. So,
Okay, so what I understood from your talk means, so once you start, so you start the oral line and you check for the ferritin, how much
No,
ferritin increased
no,
to
no,
know the
no. Red
response.
TIPC I will be checking.
Sorry.
reticulocytosis.
Okay, so Sonika is saying reticulocytosis. Fair enough.
It
Noha
takes
is saying
7 to 10
ferritin.
days. 7 to 10 days. Ferritin is the most sensitive indicator of uh, iron deficiency, like anemia.
Fine. So let me simplify the question for you. You are a gynecologist. One iron deficiency patient comes to your clinic, right? You
Yes,
confirm that, okay, this is iron deficiency. You started on oral ferrous
yes.
sulfate or fumarate, right?
Hmm.
Now you want to check the response, right? So what
So,
what the first test you will do to know the
so
response?
firstly, yes. So firstly, the patient's presentations will increase. There will be increase of appetite. The patient will,
So
there will
so
be a
so super excellent. This is what I want. So
well-being.
so you mean to say first improvement is a symptomatic improvement in
Yes,
general, isn't it? Yes or no?
yes, sir.
Okay, fine. After symptomatic improvement, what improvement happen?
So within 1 to 7 days, there will be reticulocytosis,
Okay, so
and by
reticulocytosis.
yes, and 1 gram will increase after 3 to 4 weeks. 1 gram
Okay,
of
so third
increase in
thing is the
HB.
hemoglobin. Incremental in the hemoglobin is the third place. It
Yes,
won't be in the 1 or 2 day or 3 day, right?
yes, it will be after 3 weeks, 3 to 4 weeks.
Fair enough. Fair enough. Any comment? Dr. Ramida, any comment?
Yeah, I think it is reticulocytosis because
Excellent. Reticulocytosis. Absolutely. Now I'll go to the excellent literature for you, probably physiology, but it's important. Yes. So it's a very important. Now see here, what's the beauty is that when you start, 1 second, let me remove. Yeah. So when, say for example, patient has a hemoglobin of 8 gram, you started per oral iron, right? First and foremost things, time after iron administration. So one day, within 24 hours, all symptomatic improvement. Remember in that way, very important. So when patients comes to you, you ask for the symptomatic improvement, which is the considered to be the earliest. When you replace the iron, when the RBCs are forming, you get a symptomatic improvement. First thing. Second most important thing in 1 to 2 days, right? Bone marrow erythroid hyperplasia. So this is in bone marrow erythroid hyperplasia, which is not in the options. And this is not a practical options for me being a hematologist to do a bone marrow on day 2 to know the iron response. It's not practically feasible for your knowledge. Within 2 days, 3 days, reticulocyte count will start increasing. So this is the first, this is the answer. So whenever you want to check your iron deficiency, anemia patients, whether they are taking oral medicine, whether compliance is good or not, whether absorption is good or not, whether patient taking or not, everything will reflect on reticulocytosis. So if reticulocytosis increase means until proved otherwise, you are going on a right track. Patient going on a right track. Everything is going smooth. But if retic count is not increasing, means number one thing is patient is not taking iron. That is the biggest problem across the globe. That is called as a compliance. You tell the patient, and especially in female, don't take it otherwise. All females respected in the group. Usually my patients, I'm hematologist, so I give 3 months of course. Hardly female takes 10 days, 15 days. That's all. I'm fine. I'm better. I don't need to take. Absolutely fine. This is the mindset, right? So they usually not take and complete the course. So iron deficiency will never go away. They always have. I know thousands of female. They are every day telling me, sir, my hemoglobin is only 9 gram% for many years, not increasing. I did everything. They have not done anything. They have not evaluated ever in their life, and they believe and don't take it otherwise. Even female doctors are believing that 10 grams of hemoglobin is normal. So it is absolutely wrong mentality. Female, menstruating female, at least they should have 11.5 to 12 gram, right? Female, non-pregnant and menstruating. Pregnant, at least 11.5. Non-pregnant, menstruating 11.5 plus, and male 13.5 plus. Plus it could be 14, 15, well and good, minimum 13. So here 13, here 11.5. It is normal range. But you considered being a female and doctor, oh, 10 is normal, okay, I'm fine, blah, 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 blah. You never investigated, na? Either you have anemia or chronic disease, either you have iron deficiency anemia, or you must have some excessive menstruation. These are the common problem in menstruating women with anemia, right? But you need to evaluate. 10 is not normal. Go and read any book in the world. If 10 grams is written normal, send me the picture directly. This is my number. This is my number. I read hundreds of books so far. Being hematologist, there is nowhere 10-gram hemoglobin is normal in female. Fair enough. So let's get back to this. So first is the symptomatic improvement here at the answer of our questions. So here symptomatic improvement, then bone marrow, erythroid hyperplasia, but practically will not do it. Reticulocytosis count, and then hemoglobin. This is usually in 2 to 3 days, but max at 1 week. I done many times retic in my practice because I see hundreds of anemia every day as a hematologist. So I do right after 1 week. I'll do usually CBC and I do retic count. CBC after 1 week, hemoglobin is also increased within 1 week, 4 days to 30 days, anytime. But I have seen many increment, right? 7, 10 days they increase little hemoglobin. So I'll do CBC and retic count. Absolutely, retic is increased. So when you diagnose iron deficiency anemia at that time, retic count is 1.5% with 8 grams of hemoglobin. After 1 week, picture is it could be 8.5 to 9 gram, right? And 1.5 to 3.5. So increase in retic, increase in hemoglobin, but at least I expect to increase the reticulocyte count as the earliest response. And lastly, the ferritin will increase. So somebody has given the answer ferritin. So don't do the ferritin. First, what happens in the bone marrow? Bone marrow erythroid hyperplasia will develop. Then reticulocyte count will increase. Then hemoglobin increase. And once the hemoglobin is become normal, like 13, then we give 3 more months oral hemoglobin to replenish the store, sorry. And lastly, the ferritin will increase. So ferritin will increase last. It's iron store. Everything is normal. Then you give 3 months. So ferritin so here three parameter: iron deficiency 8 HB, 1.5 this retic count, and ferritin is say for in female less than 30 is considered as an iron deficiency in menstruating woman, right? So hemoglobin become 12, retic count after 3 months is normal, but the ferritin will increase last more than 50 plus after 2 to 3 months. Once you give the complete course, so ferritin will not increase earlier, right? But if the ferritin is low, it is called as the iron deficiency anemia. Most sensitive marker. There is no differential diagnosis of iron deficiency anemia. If you want to diagnose any patient in the world as iron deficiency, do one test, ferritin. If ferritin is low, your job is done. You don't need to do any other test, no retic, nothing, no bone marrow, nothing. Low ferritin is equal to iron deficiency anemia. That's all. So this is what the thing is. So very important because everyone, you can't refuse me that, sir, oh, I have not seen the iron deficiency. I never treated iron deficiency. I never diagnosed. Every other patients in developing countries iron deficient. Even with a good family, good economical status, they are iron deficient. And in female, especially because of menstruation and poor oral uh, nutritious food. That's all from my side. I think I have spoken 1.5 hours. Now, I wish few quickly give the feedback how you enjoyed the class. I have many things to discuss, but probably in the next class, we'll discuss more questions, more new questions. And let me tell you one thing, those few people are believing that these questions are repeating in mock test. So I guarantee you not a single question will repeat in every Sunday, any mock test for your knowledge. So every mock test is a different. Yes, any comment now? Comment in the group, any comment? How did you enjoy? How you had a concept clarity? Sonika, how was your first class
It was
experience?
awesome. It was really very nice. Like, I didn't expect it to be this interactive. Like, I thought, I'll be the one who will be the quietest. I won't answer any questions or anything, or I
Fair enough.
won't be remembering anything. because
Fair
it's
enough.
been
Next
some
time you
time.
will you read more and will interact more in the next class. But you enjoyed overall the concept clarity.
Yes, yes, yes.
Wonderful. Yes, Ramida. How was your experience first day, first show?
Yeah, it was a very interactive class. I was late in joining,
No
but
problem. We'll
I
send you video
think,
as well.
yeah, thank you. And I think this is after a long time getting into a class. So maybe that's the beginning blues are there.
Don't take it otherwise, but you are taking the class, so it's difficult to get into the class of someone when you are taking.
Yes, yes.
So let me introduce Dr. Ramida is a consultant physiologist, right? So she's MD
Yeah.
physiology, so much beyond me. Anyway,
No ways.
and
You're being very
yeah,
humble.
yes, and how Dr. Your Javika, how was your experience? First time you joined,
Yes, sir. It was
knows
great. My exams are so close right now, so I'm a bit nervous, but it was good. It was really enjoyable.
excellent. So you just concentrate all on your topics and all everything. Yeah. Yes, Dr. Kalhangara, how was your experience? Because I know a lot of doctors who joining regularly, but
Thank you
some
so much for the session, sir. It was very
want to.
interactive and many concepts in one topic, many concepts are getting covered.
Wonderful, wonderful, wonderful,
Thank you
wonderful,
so much.
wonderful. Anyone else? Last but not the least, old player.
Sir, how to join the YouTube classes, sir? Like you said in the
You just
initial
you
thing.
you just join it, no? Subscribe it. You are in. That's it.
No, but I'm getting only mock test links there.
No, no. For everyday regular classes, you need to join the coaching. Like the way I present, there is a everyday classes like me, but different various. We have 10 doctors minimum in our team, gynecologist, pediatrician. I introduce as well in the beginning, right? So they will
Yeah, yeah.
deliver you lectures. So you approach me later on. I'll guide you personally.
Okay.
Yes. Anyway, last but not the least, anyone? Dr. Sidra, Sabah Khan, Lalit, how did you enjoy it, Lalit?
Yes, sir. The way of delivering the knowledge and conceptual clarity was great. I mean, I learned many new concepts today.
Excellent. This all concept, I have same video, hundreds of videos are there. That is why I'm telling you, if you see that video, at least your half DHA, half MOH is covered by just looking one video a day. The rest of the things you can do it. You feel free to ask for any help. Yes, Santosh. You also, I think, joined the first time in my class, hopefully.
Yes, sir. No, it's not my first time, sir. I had already joined also. But
Wonderful.
during your class time, it is so thoroughly that I think I got to know so many questions from a single question. It's a very interactive, very good class, sir. So I'm enjoying
Thank
it.
you. Thank you very much. Thank you very much. All right, doctor. So let's connect again with the next Sunday. Keep in touch with me. Feel free to call me for any help. I will be available. This is my number. Of those who don't have my number, just keep with you. This is on the bottom. This is I'm highlighted 98255788080. Feel free to call me for any help. Thank you very much and see you in the next class. Thank you and enjoy your Sunday.
Okay, thank you, sir. Have a
Thank you,
good
sir.
day.
Happy weekend.
Thank, thank you very much. Thank you, sir. Thank you.